Yeah, it's a little like the Mad cartoon. So we'll go through research, kind of talk about, one, how the designs are created, where our part of it is, kind of where our interest is in. I think we might go around a little bit after we go through currently what our current research studies are, and just kind of talk about kind of our best kind of favorite things about research or stories about research we may have. I'm going to have Russell start us off as far as the clinical design and kind of phases of FDA studies, and kind of lead us into IITs and kind of come back.
Perfect. So we thought we'd just highlight real high level the different kind of clinical research trials that are done. And the three kind of main areas, the two that are most commonly seen in the eye care space are IDEs or INDs. So IDEs, investigational device exemptions, are for most device-based items that we see and do. And an IND or investigational new drug is for any medication, whether it be drop, injectable, or otherwise that we see. 510K de novo pathway is sort of a shortcut pathway that's sometimes used, but we don't see a lot of that, but can be used to streamline the process in certain exempt settings. But most studies that you hear about, most big new device or drug studies, are going to be IDEs or INDs. And then you also oftentimes hear about what would be termed the phases of clinical trials, phase 1, 2, 3, and 4. And I think it's also just helpful to understand, phase 1 is truly like very limited in size, very safety oriented. And oftentimes this is, in the world of drugs would be, young, healthy patients who don't have even the disease that's being treated, but you're trying to demonstrate safety of whatever medication's being applied. And then phase 2 is oftentimes where you're looking at responses to new treatments, and oftentimes, particularly in the drug space, looking at different dosings of medication to try to decide. So as an example, when we did the iDose study, the phase 2 study of the iDose looked at a fast-eluting or a more quickly releasing iDose and a slower eluting one, and placebo. So there was 3 arms, but was looking at a fast elution, slow elution, and timolol. And what it showed was that the slow elution and fast elution had a similar IOP response, but the slow eluting one had a longer lasting effect. So it's a smaller study that then allows them to set the stage for the phase 3 clinical trial. And the phase 3 clinical trial is what we really think of as the trial that's going to either bring something to market or not bring it to market. So it is the big trial. It's usually in the hundreds of patients, sometimes thousands of patients. If it's a drug-based study, companies have to run 2 identical studies. So we'll talk about, with Lens Pharmaceuticals and Fizz, which just came out, we were part of that study. They had to run 2 identical drug studies on the same population to demonstrate effect similarly. Devices, you don't have to do 2 of the same. But those phase 3 trials, then they take all of that information, collate it together, take it to the FDA, and try to get approval. And then oftentimes, again, phase 4, which would be termed post-approval studies, sometimes the FDA will say, hey, we're going to approve that with an asterisk, with a but. And the but may be, hey, you studied this for 3 months. We would like you to find a cohort of patients that you continue to follow this for a year or 3 years or 5 years. Or in the glaucoma space, hey, we want you to look at endothelial cell counts for these minimally invasive glaucoma devices because one of them was pulled voluntarily from the market because of endothelial cell loss. So now we want you to go back and establish that it's safe to do that. So most of the studies that we do in the eye care space are primarily phase 3 and then some phase 4 studies. Occasionally we'll participate in a phase 2 study, and we've done that for some corneal endothelial growth factors and other things. But most of the studies that we participate are phase 3 or phase 4 studies. And then the last kind of study section would be, again, there's other study designs that we see like bigger picture that we're not doing as much clinically, but epidemiological, observational genomics, which is particularly in the retina space. And then the other one for us that's big is what we call an IIT, or an investigator-initiated trial. And honestly, this is like the most common thing that we've done historically, and sometimes it's just, hey, we have a question as a physician, as a provider, and we want to know the answer to it. And so we just say, hey, we're going to study that. And sometimes we'll just study that on our own and, have a student who's going into optometry or medical school that's really motivated to help us collect some of that information. Sometimes we'll approach a company and say, hey, gosh, we think it'd be really interesting to look at with direct SLT, what if you were doing treatments every year proactively? Just like we get a dental cleaning every year proactively, as opposed to wait until you get a cavity to get your next cleaning. And so we can approach a company and say, hey, we want to look at this as an investigator-initiated trial. We'd like to explore this, and do you have any interest in helping financially support that or providing some stipend for a patient or otherwise? So those are kind of the broad categories that we'll go, and then I'll let you, if there's other questions for others.
No, I think I'd add, as far as IITs, I think it allows maybe a little bit of creative think around whether it's a lens, whether it's a drop, whatever it may be, to answer additional questions that we may have. Or maybe from what we've seen, based on a trifocal lens, for instance, that maybe has been approved for a few years, we've seen some kind of commonalities as far as what patients are experiencing. Maybe it has to do with glare halos, maybe it has to do with quality of vision, distance, mid-range, or near, and allows us to kind of put something together, partner with kind of leaders in industry, whether that's Alcon or Lens or whatever it may be regarding, and talk about, hey, we have an interest in kind of digging this up a little bit and partnering with you guys to enroll a number of patients and kind of actually gather the information, as opposed to just having maybe more of just a gestalt feeling about this is what we kind of see and this is how we talk to patients. We'll kind of get into that, I think, in one of the studies that we just started enrolling.
And I think it's also unique, on that trial or on that list of IITs, one of the things that we looked at was, hey, what are our outcomes for severe glaucoma with MIGS-based approaches? What are our outcomes with pigmentary dispersion and pseudoexfoliation? Because those are clinical questions that weren't answered, and many times the FDA trials are going to exclude those patients. So there's not data on how it works in pseudox, or not data on how it works in pigmentary dispersion, or not data on how it works in severe. And so to be able to ask that, it also then gives us data when we go to a insurance company and say, hey, we want to appeal your denial, or you're saying we can't do this in a pseudoexfoliation patient because they don't have primary open angle glaucoma. We can now go back and we can say, okay, well, here's this clinical trial, here's the data to support this as being a great treatment, and we think that you should support it, even though the FDA labeling might only be for primary open angle glaucoma. These secondary open angle glaucomas, there's equally great efficacious use of these stents. So they provide a great value for our patients moving forward too.
Yep. And I have one comment on IITs, and they don't have to be surgical. If you had an interest in IIT, there's lots of companies in optometry too, with glasses, contact lenses, that they wonder if you use this topical medication, does contrast improve when you're using a certain multifocal lens, if it's this artificial tear formulation versus another. So there's lots of opportunity, even in optometry offices, to do IIT research as well, if that's something that would maybe provide some intellectual stimulation and kind of provide something new into your practice if you're looking for something like that. Again, it doesn't have to be a surgical IIT to be valuable.
Any comment as far as your experience, just as far as, have you done any IITs just along optometry guide?
So before I joined Vance Thompson Vision 5 years ago, I was in an optometry clinic that did a lot with contact lenses, and so we did a number of contact lens studies. No, I didn't do any IITs on contact lenses, but all you have to do is just approach your rep and ask if the company has any interest or any initiatives that they would like supported, and then they would give you their ideas on hey, we'd like to see ideas around this. A lot of them are around multifocal contact lenses and ways to improve contrast. So again, if you're into that, we can talk as a sidebar afterwards if you're interested in getting into that kind of stuff, but there is room for IITs in optometry.
Yeah, I would add, I think research it's a lot of work, most of which we don't do. It falls on our research coordinators. I forget what the value is, but
the rule of thumb is sort of for an hour of patient interaction, there's probably 3 to 6 hours worth of paperwork and other items to enter into the electronic database and other stuff. So, yeah.
But also very rewarding is what I was going to lead into. It is very rewarding. I enjoy that part of it. But there's a lot of legwork that our team does, both Fargo, here, and in our other sites as well. As far as, kind of why we do research, obviously we have our reasons. Patients may have their own reasons. Again, as far as my component of it, I like seeing new things, right? To a degree, any job can get a little bit monotonous, and to be able to have components of research or trials, IITs, whatever it may be, they just kind of change your day up a little bit. I look at my schedule every day and hunt for my research patients, just because it breaks it up a little bit. Also enjoy looking at, pushing the profession as far as we can go. Obviously that goes for optometry as well as ophthalmology. Getting access to technologies before they become FDA approved, or at least being part of that study, to be able to talk to patients, currently about iStent, saying, well, we were involved in that study, or iDose, and say, we were involved in this study. This is what, the FDA protocol says. This is what we actually experienced in the study. As far as patients go, I think that's, there's a number of different factors there. Obviously, in a number of studies, our goal is to recruit patients, and typically we do that with some form of incentive, whether it's a discount off of a lens, whether it's some type of financial benefit where they get stipend for every visit that they have to some degree. But there has to be some motivating factor for a patient. There are a number of patients that just love the idea of being a part of a study and have a very kind of altruistic view in wanting to help out eye care, what their kids may go through. If they've got glaucoma, knowing that there's something familial there, they want to be able to advance it to where future generations may have access to newer technology.
And I didn't really believe that until I saw it firsthand, honestly, when talking to patients about research, because some studies are so easy to recruit. We just finished one, and it was this viscoelastic versus this one, and really no additional follow-ups, and the patient got compensated. Then there's other studies that are hard to recruit for, mainly because the criteria is pretty strict, or the amount of visits is pretty heavy. 12 visits maybe over the course of 18 months, a couple diurnal IOPs. And so when you're presenting this, more than once, I've presented it, and then before I even get to the compensation conversation, the patient's like, oh, I love research. I just did one last year. And I'm like, really? Okay, yes, let's do it. And but I'm always surprised at how some patients truly love it. And for the glaucoma studies we do, that patient's never, I have a snapshot in time. I meet them for the first time. I have 1 day of imaging, but then, if I'm going to see them 12 times over the course of 18 months, trust me, I'll have a fuller picture of your glaucoma, and you'll have more eye exams in the last 18 months than you'll ever have, and I will fully understand your glaucoma a whole lot more after this. So that's another benefit, is getting a better picture when they come back as many times as they do.
So we have a poll here. I guess we kind of went through all this. Honestly, I feel like the heavy component of it is all of the above. Obviously, doctors, we need eye care as well. We don't really get it. I think it was Dr. Steiner who told me that she hasn't been cycloed since optometry school, and she's a +4, +5. Somehow thinks that
It's not fair to throw her under the bus.
well,
she's not here. To
You're right. But in all honesty, I think participating in one gives you a little bit different perspective. When I talk about doctors participating in it, again, it's not something you really know until you do, either from one side or the other. I just finished a similar kind of viscoelastic study with a patient who said, she turned out with a great result. Again, for this study, I didn't feel like there was any difference in this new viscoelastic. We were trying to get FDA approved, but she made a comment this was very enlightening. I kind of have a different appreciation for eye care, just as far as kind of what you guys do, and it just gives a little bit different perspective. Ethical considerations, informed consent's probably the biggest component. There's a lot of qualifications that we kind of have to do, not necessarily annually, but at least every couple of years. Essentially additional CE that we're taking that kind of goes into what's required from the IRB, what's required on our end, HIPAA compliances, informed consent, different types of patient demographics. It's something, again, it's additional level of work, but I think, again, the intent is to make sure everybody's aligned and doing the same thing.
And one thing I would say on the informed consent, like that looks dramatically different if it's a phase 2 study or a phase 3 study or a phase 4 study or an IIT. So a phase 4 study, something's already FDA approved, we've been using it already, but we're checking for some additional safety, is very different than a injectable growth factor that's a phase 2 study of the cornea, and they're maybe going to be the 20th person in the world to ever have this injection into their anterior chamber. And so I think, again, it comes on us as providers to kind of understand we decline more studies than we end up doing far and away. And so we're looking for studies that we believe in the technology, we believe in the early data, but then also clearly communicating what we feel like is the relative risk profile depending on what information is available, how long-standing that follow-up is for patients so that we can kind of communicate that to them in a great way. And know if we ever have a concern about the safety that we'll pull them or stop them in that trial, and that's an okay thing.
Yeah, and sometimes it's the placebo arm that's the scariest. Like, if my patient gets the investigational product, we're kind of excited about that. And it's, what is the person who gets the placebo? What is their risk for progression or change over the course of the study period? Am I allowed to rescue them, or what does it take to exit them? So that's like a big part of the ethical thing too on when we turn down studies is, gosh, like I don't feel comfortable with if they get the placebo and their glaucoma gets worse and I can only give them timolol. Like what, some of those study protocols are like that. We can only rescue them with, a certain medication, and sometimes we feel our patients need more. And then, we never want to exit a patient out of the study. We want them to complete it, but if we don't feel confident in that arm of the study too, that's a big thing that comes into taking studies on. And we always say that we would never do a study that we wouldn't feel comfortable enrolling our own family members in. And so that's something that kind of I look at too, is not necessarily the investigational product, but the placebo arm as well.
Russell, do you want to touch on this first kind of bullet point, protocol development and study designs, maybe touch on how we partner with CROs to kind of facilitate that process?
Yeah, so one of the things, depending on what level of a study it is, the company who is studying a drug or device may individually from the company, or they may hire what's called a CRO, or a certified research organization, to help develop the clinical protocol along with the FDA to kind of say, hey, how are we going to look at this or otherwise? And oftentimes, one of the most valuable things for that protocol development is conversations with us as providers who have done a lot of clinical trials to say, hey, does this make sense? Do these inclusion or exclusion criteria make sense? Does this follow-up interval make sense? Does it make sense to be doing, diurnal curves every month for 12 months? Well, probably not. Like, where do you really need a diurnal curve at, pre-washout in 3 months and 6 months or 12 months? And so I think, we spend a lot of energy. Like, I go to national meetings, and I feel like, honestly, like 2/3 of my national meeting is actually meeting with a lot of the research companies that we work with and the CROs, talking about future studies that are ongoing and coming up, to talk about protocol design and how do we make it most efficient. Because one of the most frustrating things or annoying things is if you get started on a study and then you realize, boy, we should have designed this protocol differently, but we didn't. And now, 80% of patients who are trying to enroll in this study are screen failing because we didn't think through the inclusion or exclusion. So actively being a part of that's a really valuable thing to make sure that the clinical studies ask the question that we want, answer the question that we want, and have really good, clean data.
And it's okay to push back on those. And I've pushed back multiple times when the protocol's been developed, and it was like, well, this is going to be really hard, and here's why. If you want us to enroll, well, here's what needs to change. And you can't be afraid to make those recommendations.
I think the other component of this is once it's gotten to that point, right, you don't know what you don't know. Sometimes you get into a study and realize this isn't designed quite as well, whether it's from a recruitment standpoint and there's too many criteria of our patient base that just kick patients out, or whether it's potentially based on the number of visits a patient may need or the amount of time it takes to gather some of these visits where my time with the patient might be 3 minutes, yet they've got a 2 to 2.5 hour visit with different imaging modalities, whether it's visual fields or ECCs and OCTs and anterior seg photos, and they're dilated every visit. Like, there's a number of things you'll kind of look back on and think, well, we probably could have curved this a little bit differently or vetted it a little bit better just from a recruitment standpoint. Nick, quick question. Favorite type of study that you would always say yes to, assuming that
I believed in
it was designed properly?
Yeah, easy. Any IOL studies are really easy to, well, I feel they're easy to enroll.
Least favorite?
Off stage. We'll talk about that. IOL studies are fun because patients often are getting, a newer tech for either free or reduced cost, and it's really frustrating when you have a hard time enrolling and you're getting a little pressure from different areas, and you want to do well and you want to perform well. But our IOL studies are easy to recruit for, and they're very rewarding.
As we kind of move forward, so as far as patient recruitment, this obviously adds a little bit of additional conversation. Again, we essentially vet every one of the patients that comes through, depending on what studies we have going on at the time, right? Any patient that walks in, whether they're in for a CAD eval or whether they're in for a glaucoma check, typically we have, anywhere between 2 to 3, maybe 4 kind of research studies going on. And so basically we're looking at anybody who potentially could benefit from it. My primary intention is, if I have a study, whether let's say it's a glaucoma study and I have a patient that I've been following that where we're seeing glaucoma is getting worse, or I feel like we're not quite getting the control we need, like that's a conversation I'll have with the patient to ask about any interest it may have. As far as the studies that we're currently doing.
Can I say one thing on recruitment too, real quick? Just, in the environment where we're at, our practice believes in collaborative eye care, and we don't do primary eye care. And, for almost all of our studies, lens studies a little different. We're getting lots of referrals that would fit that. But, for a standalone glaucoma stent, for when we were part of the presbyopia drop study for FIS, like those studies, we really rely on the community of Montana as a whole and the surrounding area to help identify patients. There's no way that we could successfully recruit and continue to bring great advanced technology, continue to be able to provide Epion cross-linking before it's approved and be a part of that trial. If we don't continue to recruit well for those studies, we won't get those studies. And the collaborative interactions that we have with each and every one of your offices to send patients that you find or identify to be a part of these studies is such a huge part for us to, one, be able to continue to offer it, both now but also into the future, because the study companies really are looking for, hey, who are our top third, top half recruiters for our previous study, because that's who we're going to go to for our next study, because they want to recruit quickly to continue to fill and be able to get answers to their questions as quickly as possible.
The glaucoma infinite study, I think is it coming to a close? Is it officially
Getting
closed?
close, not officially closed yet.
So the iStent Infinite, this is for a standalone procedure, either on phakic or pseudophakic patients. It's currently FDA approved for severe glaucoma. Obviously, our intention is to try to tackle glaucoma before it gets to that point. We use iStents in combination with cataract surgery for mild to moderate glaucoma as well. And so this study is designed to expand the label to include mild to moderate glaucoma. And so this is a 2-year visit, or 2 years of visits, 13 visits. This was a patient or a study where there's a washout period. It's only unilateral. It's one eye. So I think one of the challenges, again, like the placebo challenge as well, is I'd love each patient that's in the study to have this in both eyes. And one of the hard part of the conversations with patients with this study is you're only qualifying one eye for this study. Your other eye that also may have glaucoma or also likely has glaucoma will not be treated during the study. So we're having additional conversation about potential for SLT or just a continuation of drops with the intention that we get this approved hopefully in the next, hopefully couple of years, and then they can jump on into it to the second eye. The Alcon PanOptix Pro study, we just started enrolling in this. I don't believe we've completed any surgeries yet, correct?
Yeah, no, so this is super exciting. We just got greenlit like earlier this week. So we have some patients that are in line to have this, which will be super awesome.
Is Fargo in the study?
We are not.
Okay.
What's the patient incentive here, Russell?
I'm sorry, say this again?
What's the patient incentive here?
Yeah, so this study super cool. This is an IIT, an investigator-initiated trial. We're one of 4 sites in the nation that is doing it, and it's a comparison of bilateral diffractive trifocal implants versus a dominant eye extended depth of focus and a non-dominant PanOptix or diffractive trifocal lens. And patients get the upgraded package at half cost. So it's kind of like a buy one, get one free to participate in the study. Sweet. And then they have one extra postoperative visit at 3 months with us, where they get paid $200 to come to that visit. And it's looking at contrast sensitivity testing, distance, intermediate, and near, corrected and uncorrected distance visual acuity. And the question behind the study and why we're doing it is there's a pondering of, hey, if we do an EDOF lens in the dominant eye, but still have a beautiful diffractive trifocal in the non-dominant eye, might they get just as good a near vision out of that, but maybe have a decreased halo profile at night? So that's the hypothesis. And again, we'll be recruiting up to 90 patients here in Montana. They want to recruit about 360 patients nationwide. And then we'll do the statistical analysis and look at it. So
that's interesting, because prior to 2020, because the first trifocal on the market was PanOptix. Prior to that, you were mixing and matching lenses. And then we had bilateral trifocal lens implants. And now it's like, maybe we should mix and match again.
Yeah, well, and the interesting part, when we were mixing and matching before, we were mixing and matching a bifocal and a bifocal. So a distance intermediate diffractive bifocal and a distance near diffractive bifocal. Yep. And this is a wavefront modifying extended depth of focus. So it'll be a little different, but you're exactly right. And when we're talking to patients about it, that's what we kind of say, we used to do this all the time where we would mix and match. And it's really to look at, which outcome might be better for patients and provide better freedom.
Other component of this is that's, again, always a little easier to recruit for IOL studies because it's a pretty decent incentive. This is basically where they only have to pay for one eye. So from an upgrade standpoint, kind of we don't really use the term BOGO, but you basically have a buy one, get one outcome. And so they get everything with an intention of half price, to where our intention is still reduced reliance on glasses, distance, medium, mid-range, and near, yet it comes with half the price tag. And so a number of patients that I've already spoken to are, not waiting in line, but very interested in participating because they were ready to go for that anyway.
And the other note I would put on this study is one of the nice parts. Every study company and every CRO is a little different in terms of, do they allow us to do surgery in one or multiple of our locations? This study, we're actually able to do surgery at both our Billings Surgery Center and our Bozeman Surgery Center. So patients can enroll in either location, which is nice. The 1 3-month visit has to be at our at our Bozeman office, because that's where we have our FDA certified lane, and they would only allow it to be in one of our clinic locations for that. So it's just one visit that will be doing the vision testing, but the surgery itself for both eyes can occur in either location, which is nice.
The Chroma study, this actually just closed. I believe they have, I think, a complete number of screenings. Nick, you guys did this study as well. Do you want to touch a little bit on kind of what we were looking at?
Yeah, I mean, before, one surgeon makes first incision with cataract surgery, they inject the eye with a viscoelastic to protect all the surrounding structures. So I tell patients, our goal is to get in, take your cataract out, put a new lens in, and get out. And so to protect the eye during cataract surgery, viscoelastic is always used to protect the surrounding structures. And I tell patients it's kind of like allows our surgeon to operate within a pillow. And so this was another new viscoelastic. I forget the details. I think it had maybe a slightly higher concentration of like a hyaluronic acid, I think, component. But they got one eye with our standard viscoelastic we're using, and the other eye got this new viscoelastic. And post-operatively, I couldn't tell a difference, and that's what you want, is just any product that comes out to work better or equally as well as what we already use.
And a lot of these studies, this is a great example of like a non-inferiority study where you're trying to say, hey, we're as good as what's on the existing market. And actually, we've got to do a number of these studies where, historically the big players in the United States were Alcon, Johnson & Johnson, and Bausch & Lomb when it comes to surgical cataract surgery. So lens implants, viscoelastics, otherwise. BVI, which is the company that's bringing NuVisc, is a company that's approved in Europe, and they're now trying to bring most of their lenses and their viscoelastics to the United States. So we were part of their trifocal implant, we were part of their toric implant study, we were part of their viscoelastic study. And again, on the consent process, again, a little easier when we say, hey, this is a product that's been available for 5 years in Europe. We have great data. They're bringing that product to the US. It makes it a little easier to talk to.
Very easy.
Some potential other studies that we may be looking at, again, still to Russell's point, a pretty thorough vetting process to make sure we feel like, one, we can recruit well for it, or two, that it fits kind of our practice model and our patient base. Potentially looking at a couple of dry eye studies, one that is matched with LASIK, so specifically looking at MIBO in combination with LASIK and testing postoperative dryness. Again, I think I'll answer the question I asked Nick. I think the toughest research studies that I've worked with are dry eye studies.
Why, Travis?
Well, one, you'd think they'd be easy to recruit for. They are everywhere. They sit in our chairs every day. But I think most of it comes down from my end due to the number of testing, the vetting process, inclusion, exclusion criteria. Most of these patients are on other medications, whether it's antihistamines for allergies. Looking at inclusion, exclusion criteria for dry eye studies is like reading a novel. And it just looks like a major challenge from a recruitment standpoint. Epi-on cross-linkings going into a phase 3 with the potential that we may participate in that. We were in the early study. Definitely something I'm excited about. We know we've touched on keratoconus, we've touched on cross-linking in our earlier conversations. Epi-on just gives patients a much more rapid recovery process, much less, I should say, a shorter duration of irritation, discomfort, light sensitivity. Typically, these patients have maybe a day or two of discomfort as opposed to 4 to 5 days. And I think the more remarkable component is vision gets kind of back to normal at a much more rapid rate. I tell patients when we do cross-linking, when it's epi-off, what's currently approved, like it's minimum 1 month, could take 3+ months to get vision back to its normal state, to where epi-on definitely will fast track that process. So excited for that potential to participate in the trial, but then also with getting it FDA approved. We've completed a number of studies. We've talked about a number of these. I think the most recent one, or at least kind of worth mentioning, is the lens study with Viz. So this is the aceclidine study. This is basically for presbyopes, eye drops that are aimed at creating a myotic pupil to extend depth of focus. This was 2 years ago when we were in the study, is that right? And so they were here today. I don't know if anybody got a chance to go and talk with them. This just got approved, I think, 3 weeks ago. And my first question to the rep was, how prohibitive is this going to be due to cost? Just because when we know new medications come out, it takes a long time for them to get on insurance panels. They've got a program that their intention is to kind of almost intentionally keep it cash pay for, I believe it was $79 a month, potentially $200 for 3 months with a little bit of a deal there. So I thought, our experience with it was good. I kind of shared with the rep that I think it's like any other drop. Nothing's 100% for every patient. Some patients do very, very well on it. Other patients would say, I definitely noticed some improvement, but it didn't quite alleviate my need for reading glasses. And others might lead further into saying, it worked well, but it was a shorter duration for me. So,
and I would say the one unique thing about this relative to Vuity, which has previously been available, if you look at like the data from the trial, you didn't see the myopic shift that we used to see with some of our pilocarpine-based drops. So I think that was the one unique part about this medication is the spherical equivalence of the patients seem to stay stable throughout the treatment. So that's one nice thing about it.
We're going to move this along. We've talked at length with iDose, so we're going to kind of jump forward to make sure we give plenty of time to our guest speakers today from Montana Retina. Any questions you all may have, let's push back. Don't hesitate to reach out to me, but we'll push that back until after the Retina discussion. Okay?
Thank you.
Awesome, thanks.